All right, so we're doing a last ditch test review, and we'll be doing topics such as renal, right? So we'll go over that. We'll try to make a study guide is the plan. Renal study guide, renal study guide. Okay, and we'll kind of touch on medications. We did cover things last time, so if you don't have that video, I'll let you know where that's at. So that's you can find that. We did that on Saturday. So we went over blood, neuro, respiratory stuff, diabetes, and valve stuff, little EKG, touch, tickle. And then we're going to talk about renal stuff, right? So renal stuff. Okay, so please close your notes. So we just had a lecture on renal. We're going to try to pull out of our hippocampus. Right now, it's right in the association areas of our brain, right? The parietal lobes right now. And when you sleep tonight, it will go to the hippocampus. So you have to be able to make those pathways as firm as possible. Okay, so what does that mean? So we want to know for renal, we want to know what causes. We want to know what else? Symptoms. You want to know treatment. So I'll put probably treatment last because there's a heck of a lot of complications. Okay, and that will we'll put on treatment not covered above, right? Because for each of the complications, we'll kind of talk about not so much the causes. I guess causes like for why did you get it? Does it happen? But treatment not covered above, right? And that's easy because there's only one medication we don't give above, which is what? Well, we don't give metformin with, this is just put like interventions here. Don't give our meds. Right? Don't give meds, sorry. Don't give metformin, right? What other meds do we say not to give? For CKD patients. NSAIDs, right? But as far as like what med do you give for a CKD patient? What's the medication that prevents the CKD from getting worse? Good. So ACE inhibitors and ARBs, right? That should be or ARBs. Okay. You never give both at the same time. Yes.
We also go for diagnostics.
Yes. The complex sign symptoms, diagnostic tests. Do you have a button? You just press it. You'll hear it in the recording. All right. All right. So causes, symptoms, diagnostic tests, complications, and treatments, right? But ACE inhibitors, ARBs are what would not be covered above, right? What else? So you got interventions. We can talk a little more about interventions, but as far as causes, what do you recall about causes? Diabetes, right? So we can separate into vascular causes, right? Got diabetes, hypertension. What else? CVD, and that kind of causes the hypertension too. Anything else? Good. So I don't know if I separate into something else, but like CHF, I don't know if that's really vascular. It's kind of, let's put low flow or low cardiac output, right? So CHF, those are really the two big reasons why you have CKD. And the other reasons that we talked about on what we're going to go over here were what? This can also cause CKD, right? So let's put that like infection, right? So pyelo and what else? Glomerulonephritis. Okay, so those are the big reasons for it. Any other reasons come to mind? Lupus, I'm not going to test you on because lupus is next semester. We'll talk more about lupus, and then next semester, say, oh, what can lupus have a complication of? CKD. Yeah, pyelo is a complicated UTI, right? Really, technically, it's an ascending UTI. A complicated UTI is basically one that's someone that's had it multiple times. That's technically complicated. What's that? Strep. That's glomerulonephritis. Okay. Anything else you can think of? PKD, but we're not being tested on PKD. That's more going to be peds, but yes, PKD, other, right? PKD, and also we can think of meds might do it. Like what meds? Meds that are toxic, such as nephrotoxins, right? Such as what's a good one? NSAIDs and antibiotics, right? Those are on a list that you've got to be careful for. If someone's on this for a long period of time, they can develop chronic kidney disease. All right, so that's causes. Anything else cause-wise you can think of? or diet's going to lead to the ASCVD, right? So yeah, does diet cause CKD? Because usually these things are going to happen first. You could get the CHF or the hypertension, ASCVD, or the diabetes, and then that will lead. Is it like a wrong answer? Not technically, but it's not like the first answer. All right, so then that's causes, right? Symptoms. Yeah, symptoms of CKD. Think of the functions of the kidney, right? So what are the functions? The creation of erythros. What's that called? Erythropoiesis. That's low EPO, right? So they get what? Anemia, right? And we can put down complications down here, anemia, right? And we'll talk about those. Well, the causes, we can put, again, low EPO, right? Let's insert my little down arrow somewhere, special characters for down arrow. Okay. Low EPO, okay? And it's also due to, urea too. But anyways, what are the symptoms of anemia? We got DOE, we got fatigue, clear lungs, right? And it might be pylorus and some other things that are associated with anemia in of itself. And you can put like DX tests. What are they going to have? Low H&H, right? They'll have a low RBC count too, but low H&H, right? And then what else? So diagnostic test, treatment. What's the treatment for anemia? So PRBCs. That makes sense, right? RBCs low, give PRBCs. All right. So when do you give PRBCs? Hemoglobin hematocrit. The hemoglobin less than 7, or hematocrit 21. Okay. So PRBCs, that will fix the job, fix the problem. We can think of the complications here, right? So that's going to be kind of C above for blood, right? With complications, so side effects, right? But what are some other treatments we give? Iron, right? You get folate and B12 supplements. With iron, though, there's a few more. There's there's iron supplements, but also there's like IV iron. Okay. Also, also IV iron. Okay. And then you can put down the names there. They usually have iron in the name, right? It's like ferrous sulfate or ferric sulfate or all these other ones. And then side effects of iron cause constipation is a significant side effect of iron supplementation. Okay. So that's a side effect. And then what else? I think we're good with anemia, right? Diagnostic symptoms, diagnostic test, treatment. So yeah, we're done with anemia. Then we'll come back up here. So we got erythropoiesis. What else do you have? Let's keep it in order. Yeah, third spacing. What's that called? What's that from? Third spacing. All right. That's peripheral. What kind of edema? Peripheral dependent edema. Okay. And that's all due to what? This is all fluid overload, right? The third spacing, what other symptoms might they get if they have fluid overloads? Like, I'm not sure if I want to do what the theme is here. We're trying to put the fluid overload down here. We'll put the symptoms down here, the symptoms up there. Okay, so fluid overload, right? The reason is because of why? What are the two reasons for fluid overloads? Not so much PRBCs. That can have, so TACO is a side effect of too many PRBCs. We're talking about just independently. They didn't get a blood transfusion, they just have fluid overload. And why was that? Insert. Let's put increased what? Not BUN. BUN is not what caused the fluid overloads, but BUN is down here. So increased BUN is another complication that we'll talk about, right? But what does fluid overload due to? Increased what? Sodium, because you can't get rid of it, right? Increased sodium, can't get rid of it. And what else? No, not protein. Not albumin. Not potassium. That's another problem down here. Increased potassium is a side effect as well. It does. That's more for glomerulonephritis. We talked about protein and water. So what's the other? So you can't get rid of sodium. You have fluid overload. So sodium builds up, right? And water follows it. And what else? Another thing you can't get rid of? Huh? No, that's down here. BUN, increased BUN. No. Nitrogen, that's BUN is nitrogen. Phosphorus, no. It's water. You cannot get rid of water, therefore the water builds up. Okay? Can't get rid of it. You can't get rid of sodium, you can't get rid of water. So our treatment is to restrict, right? Restrict sodium and restrict water. That makes sense, yes? Okay. So signs symptoms, we took the signs symptoms down here to the complications, but we can reiterate them up top. But signs symptoms of fluid overload, what does that look like? They get peripheral edema. Let's just copy it, or it's down here, fluid overload. Okay. So peripheral edema, or just put dependent edema, more specific. Right. So if that doesn't make sense to you, you can say it's peripheral extremities, right? You get edematous. What else? You get crackles in the lungs. You get pulmonary edema. So you get two edemas, right? So you get crackles in lungs. What else? You get JVD. You get blood. You get all that blood volume is in the arteries. All the blood volume is in the veins. So in the veins, it's veins full of blood, of water, right? Water, sodium. And what else? Hypo or hyper? Hypertension, right? Because you have arteries full of blood, full of water and sodium. Okay. And then you can put down a complication is what? Death is always a complication. But what's another complication? You get what? Yeah, good. So that's actually, I was thinking that when I was thinking of, you get hypertension crisis, right? And CHF is, that's a significant risk cause of CHF as well. Someone has CKD, and ironically, CHF can cause CKD, right? If your data doesn't make sense, you can put it up here. How does this CHF doesn't deliver blood to kidneys? Kidneys die. Okay, so it's not pumping the blood forward. And now if you put more fluid into the heart, that's going to help. That's not going to help the heart, right? So what else? Complication, hypertensive crisis. What is that defined as? Greater than 180 over 110 or 120, right? So we have a hypertensive crisis can happen. And this happens commonly. Someone comes in the hypertensive crisis, you look through the records, like, why'd you come to hypertensive crisis? Oh, you have end-stage renal disease. Why did that happen? Oh, you didn't go to dialysis. You have fluid overload, right? And you can easily see, you can see the blood pressures are very impressive. They're like 260, right? Blood pressures, okay? So CHF, signs, symptoms, treatments, restrict sodium. What do you remember about restricting sodium? No salt. Okay. At table, right? No salt at table. So how much salt? Is 2-ish, right? And water is 2-ish as well, right? Potassium is 2-ish. Restrict K, right? 2-ish. Okay, that's 2-ish per day, right? I'm not going to fool the units with you. I'm not going to say, oh, it's two, is it two, milliosmoles or milliliters or MEQs, right? It's 2-ish, right? So so what other salt tips and tricks? Don't use salt substitutes, but these don't have salt. Yeah, why can't we use it? We just have potassium. So that's cool for someone with hypertension, but not cool with someone who has CKD, right? So down here for restrict K, we're going to avoid salt substitutes, right? So then back up here, restrict sodium. I heard pizza. Pizza, sandwiches. What else? If you're thinking about sandwiches, you can think about pickles, right? Brine. What's in brine? Olives, etc. What else? No processed foods, no, which means canned. You can also say it's kind of meats as well, but no deli meats. Processed foods, canned, frozen. All right, anything else? Okay, so we can add to it later. And then restrict water. How do you restrict water? Take it away. All right. All right, so you got a fluid count. How do you do a fluid count? You got the 2-liter bottle method, right? Yeah, so avoid foods with too much water. What is that? Jello, ice cream. Okay. Go-gurts. What's that? Yeah. All right, what other things? They can take meds with applesauce, right? Go-gurt or Greek yogurt. I guess Greek yogurt was fine, but anyways, so what else? Restricting water. Drink small. What kind of? Good. So it's like here, listen out. Listen to me. What you're gonna use your own saliva. I know you're thirsty, but why don't you drink your own spit? All right. So drink own spit. So how do you make them drink their own spit? Sour things, right? So, frozen grapes, frozen warheads. What else? Okay. What else? They can track. We talked about the tracking of their fluids there. They can when should they drink their fluids? Throughout day. Majority when? At night, morning, midday, during day, not at night. Okay. So what else? Is that good? Looks good. All right, so that's fluid overload. There's symptoms, treatment. There's no real diagnostic tests you could do. You can say like hypertension or they're damaging their kidneys more, therefore their urine studies might look bad. So what are the urine studies? So what's the urine gonna look like? So it has microalbumin, increased. Where's my arrow at? Okay, so they have, oops, they have increased what? Microalbumin, right? I think it's greater than 30, but their microalbumin is going up and up and up. That means they're spilling this protein in the urine, right? I'll give it to you. Yeah, that's what the next gen is going to be doing too. But I give it to you in the form of a case study, unfortunately. I have to give it to you in the form of a case study because that's what they're trending towards, is that nurses should be able to just read the chart, and the chart tells you high or low. But you have to know what high or low is. If it says low microalbumin, it's like, oh, is that good or bad, right? So you have to know those things, right? So you have to read the case study and interpret that. Okay. All right. So what else in the urine? Anything else? They could have blood and certain CKDs like hematuria with like certain pylos, right? Certain UTIs, and with GN, specifically which GN? Nephritic, right? Which was your DM hypertension, or not, sorry, your inflammation. Okay, that was the strep one. Glucose in the urine is going to be more diabetes. That's going to where you'd look to see if they have glucose in the urine. That's telling your glucose is too high, right? But blood-wise, what's some blood diagnostic tests? BUN and creatinine. I have dice in my office. Do you feel like you're being, so we can like roll dice and you can add the answers? Is okay. No, like, you want me to call on you, or do you want to?
Yeah, call up.
You want to call on you?
I know, just
All right, so yeah, those are my eval that I didn't call you guys by name, so I'm sorry. All right, well, I'm going to call you by name eventually. All right, so yeah, so BUN creatinine. Let me change this thing in 1 second. Switch these guys out real quick. My mic's about to die. All right, we can still hear me in the back in the Zoom worlds. Just switched mics. We have a request from the back to be heard better. All right, so let's go back here. Who's sitting there? Let's push them aside. All right, so we have someone here that always wanted to ask if they're on something on the test. All right, so what is what's how with the blood? Blood and CKD. What are some diagnostic tests? BNP? BNP belongs to what? Belongs to the heart and CHF. What is BUN and creatinine? So are they high or low? Is it still there? Yeah, BUN, what about the creatinine? Yeah, and which one's better? Better, right? So it doesn't change day to day, right? Anything else blood-wise? GFR, this is calculated, right? And is it high or low? It's going to be low. So let's look at this one. You do not have to calculate GFR on the test. Why don't I have GFR recently? That wasn't as involved. All right, so signs, symptoms, diagnostic tests, so still on symptoms, right? So you got anemia, fluid overload, and we're going to fill in the blanks here. What's to happen when your BUN's elevated? What's that called? Uremia or azotemia, right? And then symptoms, and we got diagnostic tests are just going to be your BUN's high, right? But what about complications? I think I'll probably put complications here as well. Complication, what the heck, right? You can kind of consider these signs and symptoms, right? But what are the symptoms? I'm not going to have you determine if it's a complication or a symptom of uremia. It's going to be one or the other. Good, pruritus. Who else has pruritus? What other complication? Good, asterisk. All right, so what else has pruritus though? It's called pruritus. Pruritus, all right? What else has pruritus? What are the complication? Good, good. So calcium, phosphorus imbalance, right? So symptoms, all right? Treatment, these guys have pruritus as well, right? Any other symptoms of azotemia, uremia? Say again? Uremic frost. Sounds like a hair dye on the menu. They get nausea, vomiting, fatigue. It's really, not specific, but other complications, they get ALOC, right? This is uremic encephalopathy. Right? So that's down here. So complication is uremic encephalopathy. That's when your BUN climbs greater than 100. Okay. Also, they can do what? They can bleed as well, right? Can give what to help them not bleed if they're getting a procedure or something? Platelets? No, because the uremia is just going to destroy those platelets. What is it? DD, AVP. Okay. Also causes what other complication? And the reason I spent time with this one, because it causes a lot of problems, the BUN being elevated. What's the other complication that might happen? Starts with the P. I can't type that. Pericarditis, very good. Okay. All right, so then BUN's high. As far as the treatment, there is none besides dialysis, right? So didn't spell that right. Okay, so let's talk about dialysis down here. Treatment not covered above, dialysis, right? This is AKA what? Renal replacement therapy, of which there's two varieties. What are the two varieties? PD and HD, right? You could talk about general stuff and you could talk about complications, right? Complications. Okay, so what are those? You can do it. There you go. Self-admin. Say again. So peritonitis, right? It's going to be also, what's the infection with HD? Lab C, right? So bleeding, yes. Is going to be at all the ones, right? So, well, really, it's going to be I mean, yes, you could bleed out of the permacath or vascath if you leave it unclamped, and that's happened, right? And they're going to bleed out immensely, really quick. All right. So what else? So self-administered. So 10 to 12 hours. What else? Anything else?
CD is the one that's done with the fluid. What do we think with the D?
Mm-hmm.
Oh, yeah.
Dialysate has dextrose, whereas here the dialysis has custom dialysis custom, right? You can custom produce whatever dialysis you want. And with like a hemodialysis machine, they just hook it up to tap water. That's all they do. They hook up to the sink in the room and they go in there and they have two bottles, you'll notice. Next to dialysis machine, one has bleach, not bleach, but one has vinegar, one has another electrolyte solution, and they have a little tube sticking in there. And the machine, they punch in what they want. It's like making cocktails, right? And they assemble what they want the dialysate to be. Okay. So it's not as clean. Yes, you could get an infection from that if it's not treated and such, but we're not getting into that. All right, either way. So what other complications or things happen? Diabetes with which one? Right? DM, not recommended. A DM, okay? Because it has what? Has dextrose, right? And because you have dextrose, right, it could cause, increased triglycerides too. Nope. There it is, increased, right? Increased triglycerides. Let's put hyperglycemia. Increased blood glucose, increased triglycerides, therefore it's not recommended for dialysis patients, right? Any other complications? Good, so respiratory. Respiratory compromise, right? So like considerations, it's probably not great for someone who has bowel problems, who has who is pregnant, who has back pain. All these things are going to put them at risk. Not recommended for. Respiratory abdominal issues. Okay. All right. So the infection can happen at the effluent, right? Effluent is what color? Well, with peritonitis, it is.
Oh,
Yeah, not pussy. Right. So it is purulent, right? And then also the site can be affected, right? So the site's affected, that's a complication as well, the site infection. Right? And then the reason I bring that up is because you have infections down here, right? They kind of overlap. And then the other major complication of hemodialysis is what? Good, hypotension. That's a significant side effect, right? And then what would you do beforehand to make sure their hypotension does not get more hypotensive? Okay. All right, what else? So ACE inhibitors are prevent remodeling. Okay. And you know those side effects from CHF, right? So what were the side effects again? To recap. The Angelina Jolie. What else? Cough is very, very. Angelina Jolie's an actress who got her start in the early 90s. No, I'm kidding. It's angioedema.
It's the big lips.
She's an actress with big lips. All right, so cough, what else? Hyper K. That's a perfect segue into this one, right? So hyperkalemia. Okay, so you can restrict K. What's the other treatment you're going to do? Right, so it's a big detective. There it is. All right, so hyperkalemia right here. So treatment. Okay. Big, yeah, diuretics, calcium. You can think of HVICH, hemodialysis, right? Dialysis. I can't spell dialysis. Okay, so that's the idea. But then with our KX, let's add to that because we kind of change this to crap it out, right? So how do you crap it out? Good. We got sodium zirconium and patiramir. Okay, and KX. Okay, and the slides I categorized it as, you're going to fix the heart, right? So like a priority, fix the heart, right? With what? Calcium, right? And then with then you can shuffle it around. You can move into cells with what? Insulin. What else? Glucose, albuterol. Good. Okay, and also the bicarb. So then over here we got also complication of acidosis, right? And the treatment is bicarb, right? As PO or IV drip, not IV push, right? Or IV push not recommended, I should say. All right, so then let's finish up hyperkalemia. So high K symptoms are going to be EKG changes. They could have vague symptoms like fatigue and such, but really it's going to be EKG changes, right? Such as Brady, right? You got peak T waves, wide stuff, okay? And then it goes to wide to the point where it's asystole, right? It just widens out all the way. So prolonged PR, prolonged QRS, prolonged QT, and it's going to get all the way prolonged to a sine wave to asystole, okay? Treatment, and then other things, restrict potassium, avoid salt subs, and basically they should just see in a track, avoid dead things, okay? Such as what? Dried things. Avoid energetic things or once energetic things, such as like organ meats, okay? Meats and green leafies. Okay. Anyways, that's restricting potassium. Any other tips and tricks on restricting potassium? About it, right? They need to keep track of it, and they're going to probably be taking restrict K and take crap it out meds. All right. And that was your sodium zirconium. This is the most common one we give. Okay. Yeah, Paterium is like a Harry Potter spell. All right. So hyperkalemia, uremia, acidosis. How do you know that you have acidosis? So you got what kind of ABG? What's low? Anything else? Bicarb. What's high? High CO2? Really?
Hi.
If you have high CO2, that's respiratory acidosis, right? So you're going to try to compensate by doing what? I'm asked about metabolic acidosis, what the pH, what the ABGs look like. So they have increased respiratory rate, right? So they're going to have, if you're breathing fast, what are you going to be blowing off? Is that computing? You have a low pH because you're acidotic. You have a low bicarb because the bicarb is getting utilized by binding all the acids, right? Can't get rid of hydrogen ions, right? You also can't get rid of bicarb, but the bicarb is getting utilized by it's neutralizing the acids. Can't get rid of hydrogen ions and can't get rid of potassium, right? Potassium also causes acidosis, right? So it's put up sign symptoms, the complications are going to be acidosis, right? So are we in agreement on the ABG, low pH and bicarb and a low CO2, right? Because they're breathing fast. Respiratory rate's elevated, right? This can progress to failure, to comatose state. And then yes, your CO2 might go up. Okay. So any other tricks and tips on acidosis, symptoms, treatment, interventions? There's, you're going to make sure they're breathing, make sure that you're going to trend ABGs, make sure the ABGs are good, but also fix what? Any other acids, right? Things that would kill you, right? And then would that be diarrhea or constipation? Or diarrhea or vomiting, I should say. So which one causes acidosis? Is that true? Yes, you diarrhea out bicarb. You lose bicarb. Okay. All right, calcium and phosphorus. What are any other symptoms? Low or high for calcium? Low. Phosphorus is PTH is high too. All right, but you got pruritus. Any other symptoms?
Cheek one and arm
Cheek one, arm one. What's the other one?
one.
Part one. The cheek is the chavostex. What's the arm one? The trousseau is not spelled with a CH. It's not trousseaus. And torsades. Okay. All right, any other symptoms? They might have some ectopy as well, but what else? Diagnostic tests, what's the treatment for calcium phosphate being abnormal, being dysregulated? What's the reason why calcium phosphorus is the way it is? What's low? Vitamin D, right? Binds calcium, right? The treatment, we give phosphate binders. And I'm probably gonna give vitamin D too, right? And then you might give calcium also. Okay. So what are some phosphate binders? So Velomer, right? Sevelamer, and then what else? We can separate them into constipating and non-constipating as far as side effects are concerned. So what's constipating, aluminum or iron? Iron containing, right? And we non-constipating are the aluminum ones. There is a magnesium one that the book says, but you don't give magnesium to CKD patients. That doesn't make much sense why you even give that in the first place. Yeah. Okay, so then you can put some other example ones there. Okay, and then vitamin D is recommended. What's vitamin D's generic name? Cholecalciferol, right? There's other forms of it. There's like vitamin D3, D2, D6, but so I didn't mention that, but vitamin D, to get the amount of vitamin D that's required every day, you get skin cancer first. And when you have darker skin, you have to even beat out even longer. Okay, so treatment like interventions, right? Get sun, but not too much to cause skin cancer. Literally impossible. But if you put skin block on, you're going to block the vitamin D UV rays. All right. So what else? We can encourage, can avoid what? Not the sun, but not avoid calcium. You want calcium. Phosphorus, right? Avoid phosphorus. So what has phosphorus? Preservatives have it, right? Which is like your cola has it too. What else? Things that have energy, such as meats, right? Does cheese have energy? But cheese has preservatives. It also has antibiotics. It also has phosphorus, right? Dairy. Okay. Processed foods will be like your preservatives, cola, processed foods. We've seen themes, processed foods for sodium, processed foods for phosphorus. Okay. So anything else for calcium phosphate? Acidosis, hyperkalemia, uremia, fluid overload, anemia. Okay, so let's recap at the top here. So you got erythropoiesis, fluid overloads. What else? Well, let's put anemia symptoms here just to be redundant. What are anemia symptoms? So you got dyspnea exertion with clear lungs. You got pallor. What else? Fatigue. Okay, that's pretty good. All right, and then fluid overload, got peripheral dependent edema. What other symptoms? They got JVD. What else? Hypo or hypertension? All right, hypertension. Anything else? You got dyspnea exertion with crackles. Okay. And then let's recap our other symptoms. What are the other symptoms? We got hyperkalemia, which had what symptoms? EKG changes. Okay. What else? They might get weak. They got like restless leg syndrome or something. But you got acidosis. What does acidosis have? So you don't get diarrhea with metabolic acidosis. Diarrhea causes metabolic acidosis. So what are the symptoms of metabolic acidosis? Good, you got an SNS response, right? So you got increased heart rate, respiratory rate, diaphoresis, etc. What are the complications we got? Good, calcium phosphate, right? So what's high, what's low? So we got low phosphate, we got high oops. Sorry, I selected the wrong one here. So let's do low calcium and then high phosphate, right? Okay, and symptoms?
Suicide and
So if you don't know, just grab what happened. All right, Chavostek. Right, so let's put images and let's grab it. Yeah, there we go. That looks good. Okay. Oops.
I just happened to it.
Okay, so Chavostek, it's right here. Let's make that smaller. Okay, you got Chavostek and you got Trousseau's, right?
I wouldn't bet it. I would not put it past
I
it.
wouldn't be mad.
All right, there's Trousseau's.
That's on the test.
There you go.
That is on the test.
I wouldn't be mad at it.
Okay,
Torsades, which is-
all right, and Torsades. What does Torsades look like? There's a lot of Harry Potters in the room. All right, there's a good Torsades. Let's grab this one, let's copy that guy. Okay, all right, there we go. So calcium, phosphorus, you get that, but you also get what other symptom? Starts with a P. Pruritus, right? And then what other, that should make us think of what?
What happened?
What should also pruritus, what's another complication that should make us think about? Good, azotemia. We got a Greek in the back. We got azotemia. Of course, nitrogenous waste products are elevated. Okay. So that is also pruritus and other symptoms such as can they bleed? Bleed. Pruritus. Good. Encephalopathic.
Go, girl. I'm not.
You got asterisks, right? What else? They got another P thing. Good. And one of the complications is hypertension, which is not great. Okay. Are any other symptoms we're missing from these guys? Think of the functions, right? Fluid overload, third spacing. I don't know if I can link it to fluids or not, but let's put other. I don't know if I put it at the top or the bottom. Let's put it at the bottom. Other. What's just someone who has renal failure? You say, oh, I know you have renal failure because you have what symptom? What is it? You see, you look in the eyes and they yellow in the eyes is more is jaundice and liver failure and such. They have oliguria. Good. So oliguria can't really link to the other ones, right? Yes, maybe fluid overload because you're not peeing the fluid out. It's you're oliguric, but oliguria is kind of its own little deal. Okay. What is oliguria? Okay. Anuria is none. It's like the less than 100 per 24, I think. All right. Whereas oliguria is like less than 400, I think. Anyways, this is little urine. Okay. So what else do we know about kidneys? It causes, symptoms, diagnosis tests, complications. And then we did kind of dialysis as well. Are we done? All right.
Now it's all the
Well,
questions.
all right, let's open our notes and let's look to see if we missed anything.
You don't want to ask. I keep it to a test. Are you gonna ask us about murmurs?
Murmurs, yes.
I need pictures
Pictures, yes.
for the murmurs.
Murmurs, yes.
Pictures and murmurs combined together.
Mhm.
Can we go over that right now?
Bro, I the ones I got wrong.
Those are the ones I got wrong.
You think it's important that you should know it? That's why I'm testing you on it, if it's important.
We're gonna see it in a question.
You can assess it.
I'm gonna check.
The patient's gonna whisper it to you in your ear.
I'm gonna check.
All right, are we looking at our notes? Anything we're missed? All right, so that took us 30 minutes to do the whole thing, right? So it should take us, if you're studying this, you should probably get it down to 20 minutes or 15 minutes, right? If you're breaking it apart into like groups, you could say, hey, you do this complication, you do that complication, you do that complication, like 2 to 5 minutes apiece, right? It should be more and more practice recalling the information. That way it becomes more and more comfortable, okay? The staging, no. Like do they the GFR is 60? What's their stage? No, that's not going to help you in real life. I mean, if it's GFR is like 30, 20, 15, yeah, you're pretty bad. But that isn't that's not going to help you as far as acute, as far as the prognosis and such. That's not our thing. Okay. What else? We feel good on renal? That wasn't on the to-do list, but we can put it on the to-do list. Oh, it kind of was. All right, so let's do Pylo. Are we good on CKD?
How many questions are there? 25. Oh, hell no. No, that's Neuro.
Oh.
I think it's 12.
I thought Neuro was more.
No. How much? 26. And 12 on stage
All right, so pyelonephritis. What do you know about pyelonephritis? I don't know. All right, so what else? Good. Symptoms are FDUF. So what are the symptoms? You said flank pain, fever, chills, malaise or salt and vinegar? No, malaise. So D stands for dysuria, which is painful urination, right? So U for urgency and F for frequency, right? And we could do diagnostic tests, right? What do diagnostic tests look like? You get cloudy, right? With nitrate positive or leukosterase positive. The diagnostic test, you might have hematuria. You could do a ultrasound. The ultrasound of kidneys would look like what? Might have hydronephrosis.
Oh.
So we forgot up here, diagnostic tests are going to be big or small kidneys. Here. We're talking about CKD now. So the ultrasound of kidneys equals small shriveled raisins, 2 scoops. Okay, so what else? Diagnostic test, that looks good. Also, they can have like a white count elevated because it's usually a systemic infection. It's much, much worse than a regular UTI. Okay, so it might have like white blood cells on serum and urine. Okay, what else? Causes, any other important causes? Good. So we got a COTI, right? This is due to Foley catheter, right? What's that? Pregnant, you're more at risk. Good. So that's because it could compress the ureters and cause stasis. And also other reasons, anus less than urethra, but there's also STIs. There's like obstruction. Yeah, that's what we saw down here. We had obstruction with kidneys. If stone or obstruction, right? Due to what? What? Calculi, which is a stone. We got a team Greek in the back. It's okay. All right, stone, calculi, obstruction due to a growth, right? So that's a fetus or a cancer, right? That can do it, right? Or they have a prostate. That can do it too. Okay, so BPH, baby, or Banser. All right. What else? So the symptoms, diagnostic test, treatment. They usually be on what? It's a serious infection, so you have serious antibiotics. For pain, you're going to be on what? Peridium, which is the brand name. What's the Benazo? Something. Benazopyridine. That's what. All right, so then we got a lot of interventions to recommend, right? Complications are is sepsis, septic shock, but that's next semester. But interventions are what? This is kind of like prevention, right? But also, I could kind of tie this into antibiotics. What's the interventions for antibiotics? No, interventions for complete course, right? Not just when feeling better. Okay, other interventions you recommend. So we got anatomic, right? We also have what else? Because what a bacteria like? And alkaline, right? So we got to make sure we avoid sugar, right? So that means we're going to unsweetened things, right? There's also avoid caution with what diabetes medication? Metformin is up here. Meds don't give metformin for CKD, but what about someone who has a UTI? What diabetes med would you avoid? Where's our German Harry Potter at? He's gone.
He's gone.
He's become a Horcrux. Lozens, yeah, so. All right, those ones caused perineal problems. All right, unsweetened things, but also before we talk about unsweetened things, let's talk about alkalinize. We want to alkalinize or we want to acidify? What do we want to do? Ascorbic acid. All right, so acid to acidify. Okay. I can't type. Acidify. All right, so then anatomic we mentioned back to front or front to back? Front to back. Okay. I think the song was stuck in my head. I don't know.
Let's see, a stupid picture. I'm gonna get confused. I'm gonna picture like.
All right, so anatomic. So we're gonna. So anatomic, we're gonna void, right? Prepoist coitus. Okay. Before, after sex, yes. Supposed to go before too. I put pussy. I didn't put anything else. All right, front to back, prepoist, and what else? No bubble baths, no douche. And that's really alkalinizes, destroys the pH, right? So over here, I think it probably been under acidify, right? No bath bombs. Can't go to Lush. Okay. So what else? Anything else? Good. Anatomic, we want to flush. Let's put anatomics. So flush kidneys. That's probably this one here. Okay. We're gonna drink, right? Drink water. How much water? 2-ish liters or 8 to 10 cups, right? And then what else? You want to make sure they get flushed, make sure the bacteria can't hold on, right? Like they're free climbing the front face of Mount of Half Dome, right? You want to make sure it's super slippery. How do you make it slippery? drank what? Cranberry juice. Sweet or unsweet? Unsweetened. Okay.
Not very sweet.
Better read that label.
All right. Anything else? Any other tips or tricks? All right. So that is pyelonephritis. It took us a good 10 minutes to do that. Right. That was our first time attempting. The second time you do it, you should be much faster, much faster. You should be able to recall that much quicker and quicker with each pass, at least. Okay.
Oh, but the Pagaphosin come up?
So good. So treatment, you might have to take the stone out, right? Remove obstruction, right? I mean, surgery or nephrostomy. They put a tube in the renal pelvis and it drains the fluids. Okay. All right. So then glomerulonephritis. You still want to go over that one? You missed your opportunity, sir. All right. So glomerulonephritis, what are the symptoms or what are the causes? So you can separate it into two, right? So it's nephritic and nephrotic. Okay. Is due to inflammation, right? Infection, inflammation. All right, strep, right? What's a strep infection look like? It's strep throat. Or impetigo. And nephrotic is like damage to the glomerulus over time. There are other reasons for it, right? So is the clogs. That's what are the antibodies called? I think it's TSO or something like that. What is it called? Streptolysin antibodies, SLO. Anyways, a nephrotic syndrome. So you have a damage to kidneys over time. So one we're familiar with is DM and hypertension, right? And then symptoms, so nephritic, nephrotic. So one of these has protein. Which one is it? Right? You get protein in urine, they lose albumin, right? And which holds on to water. Okay. So they get what? They get facial edema, right? Facial body-wide edema. This is called anasarca. Okay. And then they also have hypertension for a different reason than these guys have hypertension. Okay. So these guys get swollen shut, basically. The glomerulus gets swollen shut and clogged. So they get this hypertension. Okay. And inflammation. And inflammation that can lead to bleeding, right? That's called hematuria. What's the fix? Be antibiotics if it's due to strep. Okay. Fix the diabetes or hypertension, right? There's not much else to it. The causes, symptoms, treatments, interventions. There's not many interventions. It's like make sure you take your full course of antibiotics, but it's usually our body that created that immune response and clogged ourselves, played ourselves. Okay. All right. So look at your notes. Any other things that we missed on glomerulonephritis or pyelonephritis? There it is. No? You got it? All right, you're good. You want to take a break to recoup, or are you done? All right, so let's recoup. All right, so we're not doing end of life. All right, then there is questions at the end of life, but at the same time, we're going to try to make some practice questions on ischemic stroke, CKD, valves, etc. So let's try to make some questions here. All right, you want them to be SATA or no SATAs? SATA. All right, everybody's for SATA. 10-ish? I don't know. All right, so you want a case study with this one, right? Case study with ischemic stroke. So let's go ahead and put like a HPI in here. So let's go over here to, where's my chat GPT? All right, give me an HPI for a grandma who enters the hospital with right-sided weakness. And she has what? She has, and what else? Sort through. Could not generate. You got to relog in. That didn't help. Okay, there we go. Nice. Okay. So here's your case study. All right. So it's all right. So let's go over to this one. So we got a case study, right? So you got an HPI. That means like a history, right? History. Okay. 78 grandma is usual state of health till this morning when she suddenly developed weakness in her right arm and leg. Family noticed that she was unable to hold her coffee cup and had difficulty walking. Let's not make it too complicated. Let's say had to hold a coffee cup and it spilled everywhere. She dropped it. All right, approximately 30 minutes later, they observed what? That her speech became slurred and she was having trouble swallowing her breakfast. Concerned, they called emergency services. There was no reported headache, visual disturbance, or loss of consciousness. Yes, there was. There is headache. There's no reported headache, but had difficulty. I don't know, so had no reported headache or loss of consciousness, but had visual disturbances reported, right? Usually there'll be like tabs. The next tab might have like a history. Next tab might have medications if they're appropriate. If we're trying to get you to ask about medications, there might be like a nursing, was it flow sheet, right? A nursing notes, right? Like at 0700 took care of the patient. 0800 this happened. 9 o'clock this happened, right? And why is that important to know about the time with this situation? Good. So so what are the priorities? Let's make this. What are the priorities for the patient at this time? Okay, so what are priorities? Determine. Right. Last known time well, right, by the family. Good. Check blood sugar. All right, check blood glucose level. What else? SCT is good, but let's just say prepare for MRI. It is 0530. Okay, so what else? That's kind of last known time well, right? Airway breathing, yeah, we got to figure out if are we asking like assessment things or interventions. So this is kind of really broad. Are we talking about, what do you want it to be? Do you want it to be interventions or assessments? What are the priority? What else? Check code status. Assess vitals. National Institute. All right, so what are the options? What do you think? So A is correct, right? Because last known time well will do what? Thrombolytics. So if this was like a case study, I'd probably give you some more like timelines, like they either didn't or didn't get a CT, or how long it's been. So we said it's 5:30, right? On patient's arrival. What are on the patient's arrival? What are and the time is now. I can give you like nursing notes here. Let's do that. Notes for patient above. Patient saying like glucose was checked. Oops, stop. Didn't mean to hit go yet. Let's go edit this and say patient arrived at 05:30, and then blood glucose was checked at 05:32. Okay, CT scan, I don't know what else could be done. They could have a 05, what else? Be good. So 0600 EKG done, and then we could say 0900, it's 0900 patient doing well, doing the same. Okay, let's see what it says. Okay, so this is like on the second tab. So that you have the first tab of the case study is here's what's going on, and then here's your next tab, right? That's too detailed for the test. Obviously, it'd be like 2 entries, 3 entries, or not have a whole deal. So this requires a lot more fine tuning than I liked. All right.
Right.
There we go. That looks good. Let's change this up a little bit. So nursing notes. Why that's so big? All right, nursing notes. 5:30, 78-year-olds was admitted with right-sided weakness, slurred speech dysphagia. Vital signs are those. Whoop, let's change this. All right. Heart rate's 88, rest rate's 18, temperature's good, sats are good, alert but distressed. Blood sugar is 142. EKG shows normal sinus rhythm. Neuro team notified for potential stroke. So NIH stroke scale conducted, patient's MPO, IV fluid started, continuous monitoring, CT scan done, awaiting results. So let's just add to this. So let's just make another question here. Nursing notes are as follows. That's going to change our answers for the previous one, right? So let's just say it's a different question. All right. So this is your nursing notes you have. So what should be done, right? What should be done for this I can't say it. Ischemic stroke. I'm having a stroke. What should be done? Okay. So what should be done? So so like, what are the priorities, right? Or prepare for thrombolytics. So kind of already past that time. So we're at 8 o'clock right now. I didn't really get the last known time well for the family up here, but the time was, let's just erase that, sorry. So the time is 5:30. This is like 70-year grandma. They noticed 30 minutes later. We have to get like the timing here. So determine last known time well. So that's important because if it's greater than what, right? Greater than 4.5 hours, equals no thrombolytics, right? Possible what? Possible clot removal by catheter, right? Can be done. 24 hours, right? And then what about option B? Determine blood glucose level. Was that important? Yes, right? This mimics a stroke. Option C, prepare MRI checklist. MRI scheduled at 1000. Let's just say at 1700 to make it more aggressive. No, this is this is time sensitive. I don't really like that option. I'd probably change it to something else because you can add more to that. But then discuss end of life care. Not appropriate this time. Okay, so what else? E, assess neurological status. Yes. You need to determine how baseline. Good. Okay, so then nursing notes are as follows based on above, right? They did the NIH stroke scale, they did these things. Score is high, okay? 30s. All right, patients on NPO for dysphagia, 730. What are the next steps, right? What should be done next? Okay, so what should be done next? So we should, let's say a CT scan done and the results showed no, let's say no deficit, no findings, were negative. Ischemia and hemorrhage. So what could you be doing next? You could assess it again. That was 6:30. Usually you do it every hour. So let's throw that in here. 6:30. Let's put stable NIH stroke scale unchanged, right? Family updated. What happens next? Assess what? Recheck vitals is a good distractor, because that's wrong. What else? Doing neuro checks more frequently. Recheck neuro status. IV access, yeah. All right, so what's the timeline here? What's the timeline? 5:30, they came in with 30 minutes of symptoms, right? So it's 5 a.m. to 8 o'clock. The time is now 8 o'clock. So is that a problem, or we'll let it ride? Right? Can you do that? Good. She has AFib, but that is something to consider. But should we give thrombolytics? Last note. Oh. They're already done. Discuss end of life care.
But you said it's not ischemic, right? You said it's negative for ischemic and hemorrhagic, so why would you want to give them the
So how long does it take for ischemia to show?
Oh, you can verify anything. I love that.
Yeah. Check labs. The screen- It's all gonna collapse. So yeah, so you can recheck labs. Labs are important for thrombolytic therapy. That is important. And it's thrombolytic therapy is is that important here? Let's put bring BP.
And then we'll start at 25.
So what else? Hmm? Okay. It is relevant. Check all the labs. You can check labs for, let's just check labs including PTT, INR, and CBC. Okay. So now let's what? We're going to check the labs and we're going to prepare for administration, right? This patient meets criteria for giving thrombolytics. And why is that? Recheck vitals. Vitals were just checked, right? Were they just checked? I don't know. I should probably give you more vitals here. So that's probably, but okay. So rechecking vitals with that blood pressure that just checked, that's too high, right? So if that was just checked, that needs that's not correct, right? What about B, recheck neuro status? No, they were just checked, right? We need more. What should you be done? The time is now 8:01. Okay. So they were just checked, right? So you don't have to keep checking over and over and over if you didn't do anything, right? So option C, prepare for thrombolytics. That's yes, less than how many hours has elapsed? Okay. D, check labs, including PDT, INR, and CBC. Yes, they will determine if TPA okay, right? They're probably drawn over here. IV fluid started 7 o'clock, labs drawn. Okay. And then E, BP meds less than 180. Yes, right? If no TPA, we would give, I should say thrombolytic. I think TNK just came out like 3 years ago, so thrombolytics. So if they were not getting TPA, what would it, or thrombolytics, what would happen? Mhm. Yes, right. So before thrombolytics, right? Before thrombolytics, you have to make sure what? Less than 180-ish. Okay. All right. So that's a stroke question. So another kind of stroke question would be like, what would you do for an ACA stroke, right? Let's say ACA stroke symptoms, or you can say ACA stroke. Let's do interventions for the next one, right? So MCA stroke for the same lady up top right here. So MCA stroke interventions, right? Like nurse interventions you would do. Nurse interventions. So which one do you want to do first? So stroke symptoms, right? So you can say homonymous hemanopsia, right? Contralateral. We can say ipsilateral foot weakness. What else? So what else? Disinhibition, but what does that look like?
Doing socially unacceptable things.
And what else?
Not wanting to.
Okay, so is A correct? No, this is what? An MCA or PCA stroke, right? What about ipsilateral foot weakness? No, ACA has contralateral. A leg foot weakness. Okay, urinary incontinence? Yes, right? ACA has incontinence, right? Is wet, wild, and wacky. We didn't put a gate one in there. Gate one probably would have been good. All right, and then D, diplopia? No, this is PCA and basilar, right? Strokes, storks. Okay. And then what about E? Yes, disinhibition, inhibition. Okay. So MCA stroke nurse interventions. What are some interventions you do for an MCA stroke and you don't do?
Can you use swallowing that?
Ken? Stroke evaluation, swallow evaluation.
Is that for us or?
Is you. What is it? Say again? Nurse interventions you would do. What else? Already did a bladder one, so.
Watch it.
You're laughing.
Well, okay.
All right, so what is A? Bladder training on left? You don't have a left, you don't have one bladder, so. So is bladder training recommended? No, this would be for ACA stroke, right? What about B, swallow evaluation? Yes, right, swallow evaluation needed on all strokes, right? But it's like a mandate, all strokes. Doesn't matter what kind of stroke they have, you need to get it, but especially which kind? MCA, ACA? No, right? They have basilar and they have PCA, right? Those are recommended. Yeah, so basilar affects your cranial nerves, which affects your swallowing and such, right? And then what? C, approach on left side. Really?
So if the left side affected, the right side is out, so then the right side is moved, right?
Good.
Okay.
All right, so approach on left side, right? Approach on good side. So what's their good side? So yes or no? So contralateral, right? Which is the right side, right? Has no vision loss, is absent or there.
Gaze is ipsilateral.
So contralateral vision loss, right? All right, that's HH, right? So the right side is gone, right? So do you approach on the right? You approach on the left, right? So D, whisper on into the good ear. No, hearing is not affected. In any stroke, really. I mean, certain strokes, yeah, it can be rare, but it's not, that's commonly. Okay. What about E? Work with PT for right-sided weakness. Yes. I'm going to explain what it was, right arm weakness. Okay. So yes, right? Left MCA would affect contralateral side, which is right, right? Okay. Does that work? How many like this? That's like 3 or 4, one for each stroke.
They have crop vision and you're approaching from their left side, is it gonna matter whether or not they see the right side?
Yeah, because they're not going to be able to see that at all. It's going to be cropped in. Then finally, when you get into their view, it's going to show. You're going to show up. So you want to approach from their good side, the side they can see, right? Okay.
Like homogeneous, if you're right on both, but it was definitely on one, I could use. But it's they both like at the same time. It's still so that it's all like. So like you can, so that's kind of like, so if I put them on the right side of that patient, eventually they're going to see me just like if I put them from the left side of the patient, they're still going to see me because it's cropped in different places on both sides.
Yeah, they'll see you if you come from the left or the right. But you're going to surprise them if you come from the right.
Where you're talking about that body and creates the other side of the problem because you feel
It's going to create the left side of your vision. It's going to be, this is all you're going to see, but that is what you see, but it's the left side, right?
But they're still missing a portion, they're still missing a portion on the left side too, because it's probably left, right?
But it's crowded. The vision is complicated because it crosses twice, right? So it's contralateral vision loss with MCA and PCA strokes. So we say we have a left MCA stroke, right? Correct, right? So that means that the right side is lost on the right side lost over here, and the right side's lost over here. So I only see the left on both. It's cropped in. So I should approach from the left on the good side. If I approach on the right on the good side, they're not going to see me.
I get.
All right, so you do still want a case study on CKD? We got 5 minutes. Or are you good? Do you want a quick case study on CKD? Okay, so CKD, what do you want on CKD specifically? ALS or CKD? What's the consensus? ALS? Okay, so what kind of ALS question? It would be, you can cross with end of life. So we can talk about end of life. We can talk about, there's symptomatic treatment with the bowel issues and bladder incontinence and such.
Or right hand injury is going to affect the left side. So overall, so you'll still have half of your vision.
Okay. Are we still in the vision thing, or are we good?
I mean, I get what you guys are saying. I confuse people because I said you can still see out of both eyes, which is a true statement. But the issue with coming in from the right is because this right side of your eye on their right, sorry, this right side of your eye on the right side is going to be this thing. Yeah. But if I walk in big, they're gonna see me either way. Yeah, if you walk out of their periphery and in from either side, they're eventually gonna see you because both of them are crossed.
I think I'm just accepting that it's a hard question.
Yeah, me too. I was over it, but I just felt like everybody was still.
All right, they ask you, how do you know ALS is getting worse? How do you know ALS is getting worse? Good. So they have, you say FEV1, FVC is less than 70%, right? What else? Worse paralysis. What does that mean?
Oh, no, the opposite.
What else?
Like if you're trying to.
Incontinence.
Incontinence? Yes.
This one isn't about Alzheimer.
What else? Chest pain? What else?
Actually, right. Yeah.
We have no correct answer so far, so we gotta give one.
Yeah, it's, yeah.
Wait, FEV1 is wrong?
You basically be invisible until you cross.
I thought it was still.
Yeah. So you're looking at.
All right, so which one of these are correct? There's actually one was correct when I said all of them are wrong so far. So why is A wrong? This is for COPD, right? So COPD is where you measure their lung function, right?
Were there EMTs for any of them?
Yeah, vital capacity.
Oh, vital.
Mhm. So this is a yes, right? So vital capacity less than 1 liter is worrisome and needing intubation, right? So B, presence of downgoing toes. These guys have upgoing toes, right? Who else has upgoing toes? MS and Guillain-Barre has no reflexes technically, right? So MG, I guess could, MS does also. I'll just keep it to those. All right, so C, bladder bowel control. Yeah, that's a sign that they're not able to control their skeletal muscles and such, so that can be an issue, and that can cause a reason why they're getting worse, right? All right, it's also an issue with which other disease process also has this issue.
You put loss. Oh, I see. Yeah.
Right? Also found in which other disease process? Nope. MS also has loss of bowel and bladder control, and they get started on medications for those, right?
Put loss of bowel, bladder
Yeah.
control, or would it be like, okay.
All right, and the last one, D, dyspnea exertion. So no, this is a feature of
But no, it's not neuro.
like COPD, right? It could be with CHF, right? It could be CKD anemia. Okay.
Do we give those spots? How do you call them? Give the.
Cataquina we'll talk about next semester. Yeah, that's impingement of the nerves. All right, so that's it. Thank you guys.